Goldberg, who is a lawyer, a philosopher, a world traveler. He's a excellent jiu-jitsu practitioner and teacher, which is where I got to know Dan, and appreciate him very much in that realm. But in addition to all those hats, he's also a bioethicist here at the university. So I invited him to come tonight and give us a talk on a little bit of the historical perspective on chronic pain kind of diagnosis and management. So with that, I'll invite Dan up and go ahead and get started.
Thanks. Can you guys hear me? Is this thing on? Should be on. Let's see. Green light's on. Yes? All right, good. Okay, so thanks, Matt. I appreciate that. So again, I'm Daniel Goldberg. I won't talk much about myself, but I'm a very unusual academic creature, so it helps to understand where my background is, so you understand why I'm talking about these things the way I am. So I'm neither a clinician nor a scientist. I'm trained as a lawyer, and I'm a historian of medicine, and I am a bioethicist. So I do all three of those things with varying degrees of success. And I have been studying chronic pain and inequalities and problems in treating chronic pain for about the last 12 to 13 years. So I've got books and papers and all sorts of things. So this is my effort to do what I call Clio in the clinic. Clio is the muse of history. And so I like to joke, except it's not a joke, I got a law degree before I got a PhD. So I'm a ruthless pragmatist. And one of the reasons I like talking to clinicians is because it keeps me honest. If the things that I am interested in and I am talking about are not relevant to people who are on the front lines treating people in pain every day, like you all, then I am doing something wrong, okay? And so this is an effort to make history relevant to contemporary practices in the treatment of people in pain. That's what this talk is. It has been given to PM&R audiences before. I've been at Anschutz for a year, so I gave this at my prior institution a couple times. So hopefully it will be interesting for you guys. So I always teach the learning objectives to describe the rise of somaticism and changing models of Western medicine in the 19th century. You don't have to know what that is. We'll talk about it. To describe 19th century understandings of pain without lesion among leading neurologists. And we'll talk about what pain without lesion is as well and why I use that term. And then number 3, like I said, Clio in the clinic, to explain the relevance of 19th century understandings of pain without lesion for contemporary pain management. So the first premise I'm going to put out there is that we have problems with pain management in the U.S. today, okay? You guys probably won't push back too hard on this one. But IOM had a big report, I think it's National Academy of Medicine, sorry. National Academy of Medicine put out a big report in 2011 on pain. And they documented the inequitable undertreatment of pain is a major population health problem. So I'm a bioethicist, but most of my interest and expertise is actually public health. So I think about things from a public and population health standpoint, right? And that's where I think we're sort of going to be able to make that claim. Not to single out individual providers, right? It's not a morality play of good providers and bad providers, and we'll talk about why that is in a minute. But in the aggregate, I think it's very difficult to deny the scope of the problems. Now, whenever I start talking about pain, everybody wants to talk about what? Opioids! Okay? So, just to lay this out there, I'm not going to talk about opioids today. And there's a reason for that. Okay, what I believe, and I've been arguing this for about 10 to 12 years, nobody's paying any attention to me, that's fine. I'm not surprised that they're not paying attention to me, but I will continue to make this argument, is that we actually have two public health problems. We have multiple public health problems. One of them is the safe and effective use of opioids. That is obviously a very serious public health problem. Okay? The second, however, is the undertreatment of pain and the inequitable undertreatment of pain. And my argument is that these are not the same problem. They're related problems, but they are not the same problem. Right? Such that even if we were to effectively solve the first one, we would still have to deal with the second one. Right? And so we can talk about that in the Q&A if you want, why I feel the way that I do about that. But that's why this talk is not really about opioids. There are lots of great talks on Anschutz campus about opioids, and I go to those as well. Okay? So particular, just for a moment, talking about my sort of vision of history. Most people think of history as a line. Right? That was then, and this is now. We did things back then this way, and now we do things that way. That's the way to think about history. And there I speak as a historian, right? That is not the right way to think about history. History is alive. And the best way to think about that is the world that we live in today, or the one you're hopefully going to wake up in tomorrow, would look very, very different if certain things had happened differently in the past. Right? A fancy way of calling this is path dependency. So the world is actually created anew almost every day by things that have happened in the past. So history shapes everything that we're doing. right? All of our culture and our society. So history didn't happen back then. The world we live in looks the way it does because of things that happened in the past. If different things had happened in the past, the world would look very different than the one we live in today. Okay? So history determines the present and shapes the future it's alive. That's at least the model of history that I'm interested in. All right? So just think about it, noodle it around, even if you don't agree, that's okay. So I think when I'm talking to clinicians, I think it's often good to start with clinical cases. So let's start with a case. Okay? This is case 49. It's taken from a man named John Carsley Mitchell. We'll talk about him. He wrote a treatise called Remote Consequences of Injuries of Nerves and Their Treatment, and it was published in 1895. Don't worry, I'm not going to ask you to read that, okay? That's just showing you the page where this comes from. The patient is a man named J.D. He's a 53-year-old male. He was wounded in the right forearm 2 inches below the elbow in the 1862 Peninsular Campaign. This is a Civil War injury, right? A lot of the cases we'll be talking about today are post-Civil War injuries. He had suppurating necrotic bone for 20-plus years. This was unfortunately not uncommon for many A-ball injuries, which is the kind that where it happened. His limb was amputated in 1886. He reports a burning in the lost arm, and where the injury existed, there was a sensation as of the crawling of worms over the part. So what's he dealing with? Phantom limb, right? Phantom limb, which we know is highly prevalent, right, among people who have lost limbs, right? I think prevalence estimates I've seen, they vary, but they hover in the 60 to 80% range with wide differences in severity. Of course, not everybody has intense pain, but some kind of phantom limb sensation is extremely common for people who have had limbs amputated. So it's important to understand the puzzle of phantom limb pain in late 19th century medical culture. And again, bear in mind the third objective, we will, I promise, be linking this to things you guys see every day, okay? But going back a little bit, so what's the puzzle? Why was the problem for John Carsley Mitchell? And we'll talk about who John Carsley Mitchell was in a minute and why he's important. Okay, so it's a conundrum for changing models of medicine. Models of medicine are increasingly well entrenched by the 1890s. It's a piece of a larger puzzle regarding pain without lesion. So what does pain without lesion mean? Just so you know the term I'm using, we can't use the term chronic pain when we're talking about the 1890s because that term doesn't exist until about the 1960s. Okay? So in the 19th century, what we call nosology or disease categorization, it was highly fluid. Lots of different things would code for what we would now call chronic pain. They would use all sorts of different terms. It could be headache. It could be neuralgia. It could be dysmenorrhea. Yes, that was actually a term for pain, believe it or not. Okay? All sorts of things. So the umbrella term that historians of pain often use is pain without lesion. Okay? So it was a conundrum. It was a piece of a puzzle. What's the puzzle? Well, the 19th century, these changes in medicine, I know we have some medical students in the room, medical education looks the way it does today because of these changes. Right? You all, those of you who went to medical school and health professional schools as well, probably similar, you learned what's called the anatomo-clinical method, and that is born at this time. The anatomo-clinical method has 2 parts, what I call the twin sons. Right? The first is pathological anatomy, and the second is clinical correlation. We look for morbid, they would call them morbid pathologies, right? Some dysmorphology, something that doesn't work, that we can clinically correlate with the illness complaints, right? If we're talking in the pre-X-ray era, we would be clinically correlating them with when the patient was still alive, because the only way we see those pathologies is when? Post-mortem, okay? Right? So we're looking to clinically correlate with the illness complaints they had when they were alive. Okay? So why is pain without lesion a puzzle? It should be obvious. There's no discrete material pathology with phantom limb pain. JD's arm has been amputated. Where is the lesion? It's a problem, right? It's a problem for John Carsley Mitchell. John Carsley Mitchell was a neurologist. And we'll talk about his very famous father in a minute. Leading American neurologists denied that this was possible. So this is the frontispiece from a treatise called Spinal Irritation, which was another code word for pain. It comes from a man named William Hammond. William Hammond was super important in the history of medicine. He was actually known as the father of American neurology. He was the first president of the American Neurology Association. He was also the Surgeon General for the Union Army during the Civil War. So he was a pretty important guy. And what he said in the book, I don't think I have the quote out here for you, but what he says, there's no such thing as pain without lesion. There's only pain with lesions that we can find, and pain with lesions that we haven't found yet. The idea that pain could exist without a lesion, without a morbid pathology, was untenable. It was basically impossible. But the problem with phantom limb pain is, again, you have to locate the lesion. Where are you going to find it materially in the patient's body? It can't be in the area where they're experiencing the pain because that limb is gone. right? So phantom limb pain was a real problem for 19th century physicians and neurologists, right? So here's a well-known historian of pain named Rosalind Ray. And she said it this way. This is a great quote. At the dawn of the 19th century, physicians were looking for a pure sign which would remove the ambiguities inherent in symptoms. They wished to find a sign, the meaning of which would be as certain as that provided by the lesion found as dissection. Is this then or now? Because usually when I talk to people who treat people in pain, they say, well, this would be nice now. We would love this, right? If we could find this kind of thing. There are people doing fMRI studies of pain. This is exactly what they're trying to find, right? They want to find the lesion. They want to find something that they can image, something that they can see, something that they can clinically correlate with the patient's illness complaints. This is exactly what 19th century physicians and neurologists who were treating people in pain were trying to do. It's exactly the same thing, okay? So, the title of John Carsley Mitchell's treatise, from which poor J.D.'s case was taken, is Remote Consequences. Remote consequences. So what does remote mean? Remote can refer to, it's got a temporal dimension. It can refer to time, right? J.D. was injured in 1862. He had his limb amputated in 1886. The treatise that John Carsley Mitchell published was 1896. So passage of time is going on. It's longitudinal. That is one thing remote consequences can mean. But it could mean something else. Right? So Benjamin Brodie, who is famously treated pain, Benjamin Brodie was a British surgeon. He's known as sort of one of the fathers of modern surgery. And he treated a lot of people in pain. This is earlier. This is 1830s, 1840s, 1850s. And he basically said that any lesion that you can find in the body can, in theory, explain any pain anywhere else in the body. That's how important being able to locate the material lesion to connect it to patients' pain complaints was, right? There's one famous case, I don't think I have it out here, where this woman had some terrible, must have been some kind of trigeminal neuralgia or something like that, some terrible pain in her head for 11 years, and after sort of months of searching, he located some sort of fairly trivial lesion in her pinky. And he was basically like, Eureka, I have found it. Okay? Because, again, you have to be able to do it. So Charcot, who's probably literally the father of neurology, right? Hammond was important, father of neurology, but Charcot is extremely important. And what Charcot basically said was, he even came up with a name for these things. He called them dynamic or functional lesions. Lesions that we can't find, but that we know must be there, basically, right? So, we're going to continue with case 49 and John Carsley Mitchell, poor J.D. He says, it is remarkable that there is not in this case any evidence of the presence of a neuritis. The possibility of a neuritis ascending from the nerve in the stump and affecting the spinal cord is to be considered. But the most careful examination does not indicate any such trouble. The difficulty has a more obscure origin. So what's John Carsley Mitchell trying to do? It's exactly what we've described, right? He's been trained well in the anatomo-clinical method. He is trying to find that lesion, right? He knows it can't be in a limb which doesn't exist. Right? So he's looking for the next logical place. And it is pretty logical, right? He's looking for neuritis and inflammation, some kind of pathology, which he can use to explain J.D.'s continuing torment. Because unfortunately, a lot of these people who dealt with this, as far as we know, they did suffer for quite a long time. We don't have great first-hand evidence of that, but from what we can reconstruct, we know they did. Okay, so somaticism in the clinic. This idea, always looking for these morbid pathologies that we use to explain illness complaints, the sort of term of art that I will often use for that and other historians sometimes use is somaticism, right? So, from the Latin soma for body. We have to find the material pathology. We must find the lesion. That's somaticism, okay? So J.D. experiences pain, and he has other kinds of problems. John Carsley Mitchell attempts to understand this in terms of somaticism. He wants to find the lesion, right? You have to find a discrete material pathology that can be clinically correlated with the illness complaints. But John Carsley Mitchell cannot locate the lesion. He can't find it. So he says it must have a more obscure origin. Okay? So that's the first case. Let's take the second case. This comes from a treatise 20 years later. It's written by a man named Ware Mitchell. Has anybody ever heard of Ware Mitchell? So Ware Mitchell is actually John Carsley Mitchell's father. So the first case was from the son. Second case is from the father, okay? Silas Ware Mitchell is also one of the more famous physicians in American history. He was a surgeon during the Civil War. He worked in Philadelphia. He is also known as one of the fathers of American neurology. Later in his career, he sort of toured with William Osler because he became really interested in literature and poetry, and he actually sort of toured and tried to make a living that way. So this is Ware Mitchell. Ware Mitchell is, he was haunted by pain, to be honest with you, for most of his life based on what he saw during the Civil War, based on the soldiers that he treated. And we have pretty good evidence. There was a recent biography of Ware Mitchell that came out, and you know, there's pretty good evidence that as he lay dying in 1914, literally, he was actually still thinking about pain and the pain that the soldiers had experienced. So it haunted him for most of his life. So he wrote this treatise in 1872 called Injuries of Nerves and Their Consequences. Right? A soldier had their leg crushed in a railway accident in 1862, amputation at the junction of the lower and middle third, intense neuralgia, severe pain, and then the stump was amputated in 1863. In 1864, they took an extra inch of bone, the two nerves were enlarged and engorged, the pain continued, and it was intolerable. On June 1st, 1864, Isaiah Nott, another famous Civil War surgeon, right? He removed 1 inch of the trunk of the sciatic nerve and 3 inches of the popliteal and the peroneal nerve. So what's he doing? He's sort of moving up, right? That's what's happening from the stump, and he's sort of going up. Okay. No relief. What do you think happened next? Yeah, you guys know, exactly, okay? May 1865. Dr. Nott... I'll just keep going, okay? So, Dr. Nott justly, and I like that word justly because that's Ware Mitchell's editorial judgment. What's he saying? Okay? He's saying that Dr. Nott was justified in doing what? In moving up the leg. That's his editorial judgment later, okay? Dr. Nott justly admits that he had, quote, no very good physiological reason for so doing, dissected out the 2 large nerve trunks completely down to the extremity of the stump. So that's sort of curious for Ware Mitchell to say. You don't have any reason to do this invasive surgery, but we're going to do it anyway, and it's probably okay that you did. Why? Somaticism. Right? I mean, what else would he do? I think is what Ware Mitchell is saying. Right? There wouldn't be any intellectual justification for pursuing any other intervention at that time. Okay? Naturally, no relief ensued. Again, I know you guys treat people in pain, so you've probably seen something like this, hopefully not after multiple surgeries like this. But, right, naturally, no relief ensued, and in despair, the thigh was removed 4 inches above the knee, when the sciatic nerve was seen to be engorged and double its normal size. What do you think happened next? Case 46 continued. Pain goes on, because that's what pain does for many people, right? It just goes on. In August 1865, Dr. Nott exsected the sciatic nerve at the point of exit, removing 1.25 inches. So what's happened to poor case 46, patient in case 46, is they have basically, right, over a period of 3 or 4 years, had their entire leg amputated from stump pretty much, right, almost all the way up, I think, right? Pain returned the next day. Okay? So, how does case 46 show somaticism? Right? The seat of the intense pain, and that word, y'all, if you've never heard it, seat of disease, it's a great term, right? It's widely used for about 500 years. You can find it in the early modern era, so we're talking about 1600s, 1700s. You can find it in the 1800s. You can actually find it in the 20th century as well. And I haven't taken a look, but my guess is you could still probably find it if you looked carefully. Okay? So this idea is that the seat of the intense pain, it simply had to be in a material lesion. That's what Isaiah Nott thought. That's what Ware Mitchell thought. He's reviewing this case 10 years later. It has to be located somewhere. It has to be. Okay? And so, this connects to a theory called localization. You guys are probably familiar with phrenology. Right? Phrenology, the idea that different parts of our sort of skull and our brain is connected to different parts of our personality. Right? Made famous by famous by Gall and some other people, right? So localization is just an extension of this idea of somaticism, right? That we can locate the material pathology and we can localize it to a specific point somewhere within the patient's body. That's localization. It's part of this idea of somaticism. And that's exactly I think is what's going on with poor case 46, okay? If localization explains what's going on, we have to be able to find a lesion that serves as the seat of this patient's intense burning pain that we can't seem to relieve, amputation and resection is probably the appropriate treatment. Let's just remove the lesion. We can't find it, but we know it has to be there. So let's just remove it, okay? But of course, it provided virtually no relief. For anybody who treats chronic low back pain, by the way, this story should be pretty familiar, right? Because this is, I have a saying, and I say, what is new is old. Okay, and so this should be a pretty familiar story. And then it should be a pretty familiar story too, right? It prompted further surgeries, which is often what we find. I'm quite familiar with, even though I'm not a scientist, I'm pretty familiar with the epidemiology of chronic low back pain, right? And I know what it shows and what happens, and this is pretty consistent. So continuing on with case 46, we are not done with this poor man, okay? Dr. Knott, here's the kicker, believes that his patient was really much eased by this procedure, but that his craving for opium caused him to malinger. I said I wasn't going to talk about opioids, but I lied, okay? Right? What's going on, right? And so here, this is cool. This is at the Wellcome Library. I've actually seen this. For those of you who don't know, the Wellcome Library is, forget Disney World, for historians of medicine, the Wellcome Library is actually the happiest place on earth, okay? It's a very handsomely, privately funded, by the Wellcome, by Sir John Henry Wellcome, of Wellcome Burroughs, so the former pharmaceutical maiden. He endowed a huge portion of his estate to setting up this library, which is basically devoted to the history of medicine. It's quite phenomenal. They also have a great museum. It's free. You should check it out. And I've actually seen this. We don't really know exactly what this is, to be honest with you, or how it works, but we're pretty sure, based on the context and some surviving documentation, that this was a test apparatus that was used for the detection of malingerers, which was all the rage among the military types for at least about 250 years, right? Detection of malingerers is very, very popular, right? And we can talk about that in the Q&A if you want. But I think this is super interesting, right? They can't find the lesion. They can't find the lesion, so they're going up. They're amputating his leg piece by piece. They can't find the lesion. They can't find it. They amputate his entire leg. The pain continues. What's the doctor's conclusion in this case? He must be feigning illness. We can't find the material lesion. So he must be fibbing because he wants opium. You think that's a new thing. That is not a new thing. That is an old thing, as it turns out, okay? So putting some of these things together, pain, somaticism, and malingering. Let's talk about malingering for a little bit, because I think it's quite interesting and important, right? So malingering is the term that's often used. It's used now. They may or may not have used that back then. Other terms you can find include feigned illness. And so you can find concerns of feigned illness, especially about pain, going back to the medieval era, we find that. You can certainly find it in the early modern era, again, 1600s, 1700s, and it becomes really important in the 19th century, right? So what happens is concerns about malingering sort of start way back, starting in the 1700s, right, and then early 1800 maybe. It's mostly about soldiers. It's mostly in military context. We also see it in context of slaves, right? Slave owners were very concerned that their slaves were malingering or feigning illness to avoid work. This was a big concern among slaveholders. And that's mostly in the United States context where you start to see these concerns about malingering. But something happens over what historians call the long 19th century. Something happens. Concerns over malingering start to transmute. They start to attach themselves to different kinds of bodies, not just soldiers and African-American bodies. But it starts to move to white workers. It starts to move to women. Has anybody ever read The Yellow Wallpaper by Charlotte Perkins Gilman? So that's a story about malingering and the treatment for, quote-unquote, hysteria. And oh, by the way, what's the Latin root for hysteria? Yeah, hyster. Boom! Right? Right? So that's probably, by the way, I do not like the term hysterical. I sort of cringe whenever I hear anybody say, I'm hysterical. I'm like, not good, okay? Not a good history behind that term. And for those of you who do know anything about the Yellow Wallpaper, it's considered an icon of sort of feminist writing in American history. And the physician, just so you guys know, who was implicated in the Yellow Wallpaper is our friend Silas Ware Mitchell. Okay, so all these things kind of come together, right? So it starts to attach more to white workers, women, the middle class, the absence of the material lesion for Isaiah Knott, for Ware Mitchell. The pain becomes doubted. It becomes, there's reason to doubt. We cannot find this. It has to be there, but we can't find it. We amputated the poor guy's leg, but he's still in pain. We can't find the pathology. He must be feigning illness. Okay? So this is an engram. Engrams you have to be careful with using engrams. okay, because they're good for showing some things and not so good for showing others. But what this basically looks at is it charts, Google has a pretty wide reach, and especially in the 19th century, all these things are in the public domain. So Google's print searches, its search of print culture is pretty good for the 19th century. And what you can see is, you can see a rise in appearances of the term malingering. That's what this shows, okay? And that rise corresponds pretty much exactly chronologically with the changes in Western medicine that we're talking about, somaticism, pathological anatomy, clinical correlation, okay? And you can see it sort of steadily starts to increase as we get towards the end of the 19th century, right? That chronology is not an accident. At least I don't think it's an accident. Okay? And then we get into the 20th century. There's a plateau here. I have no idea why there's a plateau. There should not be. I haven't figured out why there is yet, but I'll let you know when I do, okay? What we can see, though, is once we get to about 1910, it starts to surge. And we know that there are actually some of the really interesting reasons why anxiety is over malingering. What happens between, say, 1914 and 1920 that's relevant to the history of malingering that we just discussed? World War I. Of course, right? We also see, interestingly enough, the beginnings of a lot of modern insurance happens during the same time, right? So there's a really well-known British physician who was an employee of the British insurance industry named John Colley, and he had some very interesting things to say about malingering, published many pamphlets, which we would now call certainly propaganda for the insurance industry. And he had a lot of things to say about malingering and fraud, and he wrote them exactly during this time, and that's not an accident as well, okay? So, Clio in the clinic, fast forward. What does this have to do? Finally coming to where the rubber meets the road for you all. What does this have to do with what you're doing, other than hopefully that you found it kind of interesting, right? So chronic pain, especially chronic non-malignant pain, belongs to what anthropologists call a family of contested illnesses. They are contested, right? Someone once referred to them as illnesses you have to fight to get at least a diagnosis of, right? So what are some other contested illnesses? You guys, can you think of any off the top of your head? Fibromyalgia. So fibromyalgia, of course, is highly coextensive, coterminous with chronic non-malignant pain, right? So fibromyalgia, that's a great one. Other kinds of contested illnesses. Okay, exercise intolerance. What about chronic fatigue syndrome? What's it called now? Myalgic ME is what it's called now, right? I think that's preferred. So really interesting, just briefly talking about chronic fatigue, myalgic ME. I'm sorry, I forgot the actual second term, okay? Really interesting is, they had a big conference about CFS ME maybe about 8 years ago at NIH, right? And the purpose of the conference was to look at the theory that there was a viral etiology for CFS and ME. Right? And outside this, and it's sort of the results leaked. This is an NIH conference, right? The results leaked. The results were no, basically, okay? We don't think so. That was the results. Outside this building were patients and patient advocates picketing. They were picketing with white signs marching around the building like a good old-fashioned strike. Why? And why would they validate their disease? Why would that validate their disease? Because it's a pathology, right? So the virus is a pathology. It's a morbid structure that they can clinically correlate with the illness complaint that they have, right? Because if they can't find it, it gets doubted, which is exactly what happens with contested illnesses. That is what happens with contested illnesses. Elaine Scarry, who sort of is a literature scholar, and she's one of the people who helped kick off the field of pain studies from a sort of health humanities perspective. She said pain is funny because it's among the most privately certain and publicly doubted sensations all at the same time. Can you convince yourself that you're not in pain? Does that work? Sort of. Right? We have some control over our pain experiences. I'm not denying that. But when you're really in pain, can you mind over matter and be like, nope, I'm good? That doesn't work. Okay? It's privately certain, and yet it's highly subject to doubt publicly. Extremely so. More than almost any other kind of illness complaint. Patients consistently report skepticism and doubt. We know this. We have extensive evidence suggesting that this is the case. Okay? And by the way, that skepticism and doubt does not just come from providers. Who else doubts the pain that people who have chronic pain experience? Who else doubts it? Insurance, family's a big one. We have very good evidence that intimate partners, caregivers, they don't want to hear it. They doubt people in pain. What about like illness support groups? And by the way, before I go on, let me just say I'm a big fan of illness support groups, okay? But how about illness support groups for people who experience chronic malignant pain? How well does that work? Okay? We have a pretty good ethnography from an anthropologist who embedded herself in a multidisciplinary pain center back when we still used to have those things, okay? And what she found was when they would have the group therapy sessions, people, and these are all people in pain, they didn't want to hear it. They'd had enough. They had no interest or sympathy in their fellow pain sufferers' experiences. So illness support groups, family members, we know it comes from providers. What about stigmatizing yourself? Can you do that? Sure. It's called internalized, felt stigma. Very common, actually, as it turns out, okay? People in pain don't usually have the luxury of denying the existence of their pain, but they can doubt the legitimacy of it. And they do, actually, okay? So that same anthropologist actually went and looked at chronic pain. She said, what is chronic pain? I really want the clinical definition of it. So let me just go to Medline and do a good search, and I'll come up with the definition of chronic non-malignant pain. Okay? She found 18 to 20 before she stopped counting. Right? So most emphasize the absence of organic lesions or tissue damage. Hopefully you see where I'm going with this, right? Maybe not. That's a problem for somaticism. That's where I'm going with this, okay? If chronic non-malignant pain is characterized or defined in part by the absence of lesions, by the absence of pathologies, then that's going to be a problem for this model of somaticism. It's going to be a big problem. We don't find, right, the seat of disease. So the proof, there, sorry. I should have gone first. I had that slide backwards, okay? There's my little joke. That's the best I can do. Sorry. It's getting late, okay? The proof is in the pudding. I used to have a picture of Bill Cosby up there, and then I realized that that needed to go, okay? So this is the substitute, all right? We're not going to be showing pictures of Bill Cosby. So there's ways to prove my theory. This is my theory. There's other people who have suggested similar things, but this is probably my theory as an example of Clio in the clinic, of using history to explain contemporary practices. The proof is ethnographies. Right? The proof is anthropologists and people who collect stories of people in pain. If I'm right, if there's anything to what I'm saying, we should be able to go and figure this out and ask them. Ethnographies of chronic pain sufferers should show somaticism. That's what it should show. And in fact, I am happy for my sake to report, they do. That is exactly what they show, right? The best example, and this is usually where I sort of end up, is medical imaging for chronic low back pain. So I'm a historian of pain, and I'm a historian of medical imaging. I'm writing a book on the history of the X-ray. So I didn't really understand how these two things came together until about maybe 5 or 6 years ago, where I started to think about this, okay? So medical imaging for chronic low back pain. Does it work? Not really. Okay, it's very hard to prove the negative, but there's a lot of good meta-analyses of medical imaging for chronic low back pain, and it's really, really hard to find evidence of benefit in terms of hard outcomes for the population of people who get these. We have very, very, very high utilization of medical imaging for chronic low back pain. We have very, very, very weak evidence of benefits for medical imaging for chronic low back pain. Why do we do so much medical imaging for chronic low back pain? A lot of it, guys. I'll show you the slide in a minute. We do a lot. We're actually doing a little bit better. There's some evidence that we've curbed the hyperinflationary growth rate of medical imaging. It's just come out maybe in the last year. But we do a lot of medical imaging, especially for chronic low back pain. So why? Okay. So, right, the number one factor that predicts utilization of healthcare technologies is what? It's been true for 40, 50 years. It's always the same thing. Well, that determines access to it. You're right. But what determines how much we use? Money? Supply. If we haves it, we uses it. That's it, right? So the number one predictor of hospitalization, it's never changed. It's always the same since we started studying for about 50 years. What's the number one predictor of hospitalization? Get more specific. I heard it. Beds. If we have beds, we put people in them. That's what we do, right? Supply always predicts usage of healthcare technologies. That never changes. It's like the purchase for Lord of the Ring fans, okay? We have it, we need it, we want it, it's ours. So look at this, and that's exactly what this shows, right? Well, the next slide shows this, but this one shows something which is really interesting, which is, yes, we love to use technology in general. We love the shiny in the US. But look, even relative to our growth trajectory of other kinds of procedures, you can see we're still using imaging at a higher growth rate. So yes, we do love technologies in general, but we seem to really love medical imaging, right? And it's growing at that rate. So there's the supply. Supply drives the use. And there's lots of studies that show this, okay? This just shows that when we have an MRI machine, how much do MRI machines cost? Anyone know? Should we ask the hospital purchasing agents? You get them in here? Right? MRI machines can run minimum high six figures. They can go $1.5, $1.7 million, more than that. So even for a big health system like this one, right, if you buy a couple MRI units in a given year, that's a pretty significant capital investment. Now, how are you going to get your ROI, your return on investment? You're going to use it. If you don't use it, you will probably be paid a visit by the hospital purchasing agent to discuss the volume of services that you are or are not providing to your patients. Okay? So look, each MRI unit results in 410 more users. Use is a technical term in health services research, but that's basically what it means, right? We know. As soon as we have it, we use it. As soon as we get the CT unit, we use it. Okay? So is that it? I give it. So I talk to my dad about this a lot. My dad is a physician scientist at the University of Miami. He's a lipidologist. And I say, why do we do this all the time? And he said, well, it's because it pays well. And I say, Dad, that is a question masquerading as an answer. Why does it pay well? Why do we pay so much for something that, at least in this paradigm of use, we can't find a lot of evidence of benefit for? Right? It's not just supply, because you all know, you deal with this all the time. Who else wants imaging for low back pain? Patients do. Patients want it. It's not just supply, it's demand. Patients demand medical imaging. We have very good evidence for this as well. They really want it. Why? Why do they want medical imaging so much? Somaticism, right? Yeah. It's not just a scientific way of thinking, and that's part of the point, right? It's a way of thinking about illness and the body in general. Especially when you're talking about chronic pain sufferers used to having their pain doubted for so long, to have what they consider, quote unquote, objective proof. Finally, something we can see, the seat of disease, the lesion itself. It's meaningful for your patients as well. They know that. They want it. They want it. Okay? So they lack the luxury of denying their own pain, but as I've said, they can and do deny the legitimacy. Self-stigma is common. Pain stigma, which is one of my central areas of research, is relatively common as best we can tell. We don't have good prevalence and incidence statistics for it, unfortunately, but all the available evidence we have, which is mostly qualitative, suggests it's pretty common for people in pain to experience. Okay? I think there are many reasons for this. I'm certainly not here to tell you that somaticism is the only reason. There's probably lots of other factors. My argument is just that this has got to have something to do with it. This has to be part of the explanation. It doesn't make sense otherwise. So the whole idea is that Clio lives, right? And that this helps to explain partly why it's so difficult to take care of people in pain and partly why they endure so much doubt and skepticism. So I'll close and we can have a Q&A, but I did want to say, for anyone who doubts Clio in the clinic, all you need today is to take a look at the brouhaha that erupted in Nature, of all places, because Nature ran an editorial about a man named J. Marion Sims 2 days ago. Does anyone know who J. Marion Sims is? So J. Marion Sims is known as one of the fathers of obstetrics and gynecology. I teach this history because he's very relevant to the history of pain. He was the man who discovered a surgical intervention for the treatment of vesicovaginal fistula, right, which is a really, really serious problem, we know. How did he do this? He experimented on slaves. He experimented on slaves. We only know 2 of their names, and I think their names are important. Their names were Betsy and Anarcha. Probably about 40 women. He did not give them anesthesia. Anesthesia was available. He did not give them anesthesia. He also had plenty of white patients, and he did not do any experiments on any of them. Outside the New York Academy of Medicine, where I was in residence as a fellow working on the history of X-ray book that I'm talking about, there is a statue right in Central Park, which is where the New York Academy is, of J. Marion Sims. And now that we're having a national discussion about bringing down Confederate statues, there is a movement to bring down the statue of J. Marion Sims, where I walked past literally every day for a month. Okay? And this has been going on. The statue was just vandalized. Someone spray-painted racist on this a week ago. Right? Nature News actually wrote an editorial in favor of keeping the statue where it was. They wrote this 2 days ago, and there has been a brouhaha that literally erupted today about this. A writer in The Atlantic actually wrote about this as well. So why is this relevant? How does this show? We have terrible inequalities in the treatment of pain. For those of you who don't know, in almost any kind of clinical setting where we look for racial inequalities in the treatment of pain, we find them. In almost every context, we find them with children, we find them with adults, we find them in outpatient settings, we find them in a variety of inpatient settings, right? And there are a lot of people, and I'm happy to say I'm among them, who think that these histories that we are discussing are relevant to why we have such devastating racial inequalities in the treatment of pain today, right? So that's my sort of last editorial comment. Not everybody's going to agree with me on that one, by the way, and that's fine, okay? But my last editorial comment to say that whether you agree or disagree, and that's okay, the history of pain is really relevant to what we're doing with people in pain today. Right, so that's it, and I look forward to discussion. Thanks. Yeah, all of them. All of the what I call the usual suspects, right? So stigma in general is a creature, and I am a stigma scholar. The last 3 to 4 years, my central areas of work in public health ethics, law, and policy has been stigma, right? So especially pain stigma and weight stigma. Those are the two things I do a lot of. So stigma actually is a creature of social inequalities, right? And that's a different talk. Ask me back, I'll do that one, okay? But it's a creature of social inequalities, and it strongly tracks them. Basically, if you are a person who is a member of more out groups than in groups, you are already more likely to be stigmatized across a number of dimensions. It doesn't have to be pain. It could be all sorts of different characteristics. But pain is certainly one of them, right? So the more vulnerable and marginalized you are, the more likely you are to be stigmatized. We have no evidence as to pain that counters that general trend. We don't have great quantitative evidence for pain stigma. Great grant, by the way. Okay? If anybody's interested in doing an R21. Prevalence and incidence of pain stigma, please look me up. I'd love to help with that, okay? There's every bit of evidence we have suggests it tracks the general trends of what we would expect to find on stigma. So race, socioeconomic position, right? Ability status. And these things usually multiply. That's how inequalities work, right? It's not just one, it's the other, right? I mean, it's how they interact. So, you know, a person of color is less likely to get adequate treatment for pain than a similarly situated white person. But what if it's an elderly person of color? What if it's an elderly woman of color? What if it's an elderly woman of color with a disability? What if it's an elderly woman of color with a disability who comes from a rural area? All these things make it more likely that that kind of person is probably going to be stigmatized for their pain. That's my answer. Right, well what's interesting is that's exactly, and I'm not saying that's wrong. I'm not countering that belief at all. I just think that's so interesting because that's exactly what the 19th century neurologists thought. And that's not a criticism or to say that it's old or, right? That they said, we just can't find the lesion because we lack the technical means to be able to do it. That's what they said. We can't find it, but we know it must be there. So what do I think about it? Like, for example, there are studies coming out about using functional magnetic resonance imaging, right, to be able to predict pain and things like that, or to clinically correlate pain. And there's all these articles that were written about this when these studies came out. It's about, it's the holy grail. We finally found the lesions, right? We found objective evidence of pain. So what do I think about that? I think anything that helps with the diagnosis and treatment of people in pain is a good thing, and I'm here for it. Right? I do think, though, that based on this, part of the reasons we doubt and are so skeptical of people in pain is because of these dynamics. And unfortunately, feeding the belief that there's some objective holy grail that one day we will find, right, is itself the problem. It's not, I'm not saying it's wrong. And I'm not saying that we shouldn't try to find better ways of diagnosing and treating people in pain, because I'm all for it. If we can, great, let's help them, right? Sure. Yeah, and I think that's great. I mean, to me, that's one of the interesting things about, so what helps people in pain? Lots of things, actually, right? There's actually lots of effective interventions, safe and effective, and I'll put it in quotation marks, but it's chronic, so you're not just going to snap your fingers and make it go away like most illnesses that are chronic. It will go and come back. There's periods of intermittency and those kinds of things. But actually, we have a lot of interventions that help people in pain, and you guys know this a lot better than I do, right? So I'm all for looking at a whole bunch of different things that can help people in pain and treating them accordingly. Right? I guess partly where I start to question is sort of the dominance of the somaticist model. The dominance of the somaticist model and thinking about people in pain and trying to help them, in my view, causes some mischief. And different people will have different views on whether the trade-off is worth it. You can probably guess what I think about it, that I think it's probably not worth it. But, you know, I understand that reasonable people of good conscience can actually disagree on that one. If you come away from this just thinking, look, there is some downside to this stuff. There is a downside to constantly seeking to objectify the subjective experience of pain. There is a downside to always trying to somaticize people's pain. There is a downside to these things, and I think, okay, I'm good. That's a win as far as I'm concerned, right? Even if we continue to use those models, that's okay. Just being aware that there are some problems with it, and that these problems are actually old, and they're historically rooted, and they're still present is pretty good. So that's my best answer to your question. Yes. I completely agree. Of course, absolutely, right? And so these models, these changes in 19th century medicine, which are absolutely part of 21st century medicine, by the way. It's not, again, what is new is old. This is where the model of medicine and healthcare that y'all practice, it comes from here. It's not just sort of a dusty curio in the cabinet. So part of it is about objectification. Right? And actually, even though that is a nasty word, objectification of illness, it works pretty well. I'm not here to say we should sort of abandon that and go back to humoralism, which was our prior sort of medical cosmology. Objectification of illness in general is very powerful. The anatomo-clinical method in general is very powerful. However, there are some illness paradigms where it doesn't work very well. And pain is a classic, and unfortunately, right? Prevalence of pain, it's probably the most common illness experience on the planet. CDC has all sorts of terrible statistics. Their Health 2006, the NCHS they had a special report on pain. It was horrifying, right? So, yeah, so pain is highly uncertain. It's highly ambiguous. Emily Dickinson is a famous poet. She has a poem, right, that starts out with the phrase, pain has an element of blank. It defies definitions. It straddles categories, right? It doesn't subject itself to these processes of objectification that seem to work so well in many other paradigms of illness. So highly uncertain, highly ambiguous. And I agree that we generally don't do a good job of dealing with that in cultures in general. I agree. And it's a huge problem. Thanks. Thanks, y'all. Thanks for inviting me. I appreciate it.